Good evening, everybody. On behalf of the Ceylon College of Physicians, you all are welcome to the 10th session of Peer Learning Periphery to the 4, 2023. This is the last session for this year. This is online case discussion by physicians away from the center. My name is Dr. Rohit Amaravitarana, the moderator of the today event. We know that the physicians working in outstations with limited resources have evolved excellent clinical skill in patient management. So there is a lot to be learned from them. Peer Learning Periphery to the 4 is a platform for the physicians who work away from the center to share their knowledge and experiences with others. In this session, 2 physicians present and discuss clinical cases in 1 hour period. Today we have 2 consultants from BH Kalawana and DGH Mathale. At the end of the both presentations, we will discuss the questions. Please send your questions to Q&A box. Let me to introduce the first speaker today, Dr. Ravindra Lokugamage, consultant physician, BH Kalawana. Dr. Ravindra Lokugamage, MBBS Karapitiya, MD Colombo, overseas training at endocrinology and emergency medicine at Winchester Hospital, London. Earlier, he worked as a consultant physician at BH Balapitiya, DGH Ambilipitiya, and TH Karapitiya. He has been a member of several researchers and audits. He is going to talk on patient with fever and thrombocytopenia. How far should we go? Over to you, Dr. Ravindra.
Thank you, Dr. Amaravitarana and CCP for giving me this opportunity. Okay, so I'm going to talk about my patient with thrombocytopenia. My patient is Mr. K, 46 years old male, a school teacher from Kalawan. He presented to my ward with a complaint of fever, headache, arthralgia and myalgia for 5 days duration. He had no cough, no skin rashes, normal bowel habits, worked in a paddy field 3 weeks back. He had no recent foreign travels. He is a previously healthy person, no history of gum bleeding, skin bleeding, epistaxis, hematemesis or malaria. He had no history of drug or food allergy. Surgical history was nil. He is a non-smoker and takes alcohol occasionally. His family history, he has no family history of bleeding disorders. The drug history was unremarkable, not on any long-term medications. He was not on any recent treatment with heparin, no past history of blood or blood product transfusion. On examination, he was febrile to touch, had no skin rashes, no petechiae, purpura, or mucosal bleeds. There was no lymphadenopathy, no scar to be found. He was not icteric. His cardiovascular examination was unremarkable, pulse rate of 100 regular beats. Blood pressure was 120/70, had no murmurs. His respiratory rate was 14, saturations were 100 on room air. His lungs showed bibasal few crepitations. Abdomen was soft. He had mild non-tender hepatomegaly, no palpable spleen. His neurological examination was unremarkable. This was his chart. First 2 days during. Let's go to the investigation. To begin with, full blood count, WBC count was 14.5. His hemoglobin was 14.9. PCV was 4.4, and his platelet count was 45 cells and he had proteins in urine, 2 pluses. His CCD was normal, fasting blood sugar was 95. To begin with, his CRP was 116, ESR was 70, blood urea was 20, sodium was 135, potassium was 3.85. His creatinine was normal, it was 1. Transaminase in bit high side, ALT was 134, AST was 127. Normal alkaline phosphatase and his bedside ultrasounds showed no evidence of fluid leakage. The differential diagnosis we considered were leptospirosis, dengue fever with secondary chest infection, typhus fever, and viral fever. The management includes bed rest, IV fluids, paracetamol SOS, started him on doxycycline 200, stat 10, 100 BD, and IV ceftriaxone was started. This is the series of full blood counts. The WBC was coming down from 14.5 to 6.3 over the 5 days of hospital stay. And his hemoglobin was remaining stable around 14. And PC was remaining around 40. And his platelets were slowly coming up from 45,000 to 95,000. Over the 5 days hospital stay, his CRP came down to 12 from 116. This patient had an uncomplicated hospital stay. It's a usual case of usual clinical picture of leptospirosis, uncomplicated patient. On day 5, discharge on oral cefuroxime and doxy. The plan was to be reviewed him in clinic in 2 weeks' time with full blood count and CRP. After 2 weeks in the clinic, I saw him and he was clinically well, had no complaints. He came with his full blood count, which was done in that day. He had a normal white cell count and hemoglobin was 14, but still his platelets were remaining 93,000. Am I dealing with infection-induced thrombocytopenia? That was my gut feeling. And I plan to review him in 1 month time with a full blood count, because this is a very common scenario in these days. Patients are reviewing clinics in 2 weeks time with thrombocytopenia following viral infections. They come with intermediately low platelet counts, and we tend to review them in 1 month time. Unfortunately, this man didn't appear in my clinic in 1 month time, so he lost his follow-up. The limitations I had during this initial management of simple leptospirosis, simple uncomplicated leptospirosis case, I had no blood picture of this man because we don't have a hematology facility in my lab. I couldn't come to a definitive diagnosis whether it's a dengue or lepto because of the unavailability of serum test. In my hospital, I don't have culture facilities, although we have started him on antibiotics. No radiology department, we do bedside scans only. Otherwise, I could have done a proper abdominal scan for this man. Difficulties in doing outside investigations, especially antibody testing for dengue and lepto due to economical constraints. 3 months later, this patient again appeared in my mail ward with a complaint of left side face, arm, leg weakness, which was lasted about 1 hour duration. On admission to my ETU, he had no neurological deficit according to the notes. His GCS was 15 out of 15. The systemic examination was otherwise unremarkable. On admission, his blood pressure was 120/80. The count which was done at ETU showed platelet count of 86,000. That was after nearly 4.5 months of the initial event. His ECG was normal. He was managed as high-risk TIA with high-dose aspirin, clopidogrel, and high-intensity statins. So this is a young patient with TIA in the background of persistent thrombocytopenia. So we did the stroke and hematology workup with the kind support of Teaching Hospital Ratnapura teams. His CT brain non-contrast was done, which was reported as normal study. We couldn't go for MRI brain because of the limited MRI facility. 2D echo was done. It was normal and with ejection fraction of more than 60%. Duplex scan carotid was normal. He had total cholesterol of 226, HDL of 40, triglyceride of 178, LDL of 122. TSH was normal 2.3. The blood picture was reported by hematologist, consultant hematologist. Hemoglobin was 13.3. It was a normochromic normocytic RBC. White cells were normal in count, total, and differential. And there were few atypical lymphocytes. Platelets were moderately low in count. It was 92,000 and with normal morphology. Prothrombin time was 14 seconds. INR was 1.1. APTT was 30.9. We did the ultrasound examination of the abdomen. He had a grade 1 fatty liver. Spleen was normal in size and echogenicity and had few uncomplicated gallstones. We did the infection screening. HIV 1 and 2 antigen and antibody tests were negative. Hepatitis B surface antigen was negative. Hepatitis C, anti-C, HCV was negative. Cytomegalovirus and Epstein-Barr IgM were negative. We went into the antibody panel. ANA was negative. Anti-beta-2 glycoprotein 1, IgM was positive more than 100. Anti-beta-2 glycoprotein 1, IgG was negative. Anti-cardiolipin antibody IgG was negative. Anti-cardiolipin antibody IgM was positive, so it was more than 100 units per milliliter. The lupus anticoagulant was done, which was negative. So the diagnosis of antiphospholipid syndrome was made, and this young man was started on warfarin. The INR expected was 2 to 3. His anti-cardiolipin and anti-beta-2 glycoprotein tests were repeated in 12 weeks and confirmed they were in high titers above 100. So going back to this case, are we late on diagnosis of antiphospholipid syndrome? And what about the primary prevention? Let's discuss. The thrombocytopenia, which put us trouble. The thrombocytopenia, less than 150 of platelets being considered as thrombocytopenia. 100 to 149 is being labeled as mild. 50 to 99 moderate. And my patient was in this category. And severe thrombocytopenia is considered when it is less than 50,000. Antiphospholipid syndrome is a clinical and laboratory diagnosis characterized by both persistent laboratory evidence of antiphospholipid antibodies and clinical complications. Venous thrombosis, arterial thrombosis, adverse pregnancy outcomes, and non-thrombotic manifestations like cardiac valve thickening and livedo reticularis. APS occurs as a primary condition and setting of an underlying disease, usually systemic lupus erythematosus. It is more common in women than in men, with female to male ratio of 3.5 to 1. There are no diagnostic criteria for APS. The clinician's assessment and judgment are critical for management decisions. In this year, 2023, American College of Rheumatology and European Alliance of Associations for Rheumatology has made APS classification criteria for research purposes. Sorry about this congested slide. So they have two main domains, that is laboratory domains and clinical domains. So you need to have 3 points of each to diagnose APLS, which is mainly for research purposes. Antiphospholipid syndrome can be further defined as thrombotic APS, obstetric APS, microvascular antiphospholipid, and catastrophic antiphospholipid syndrome. Thrombotic antiphospholipid syndrome consists of venous or arterial thrombosis. Obstetric APS has adverse pregnancy outcomes, especially IUDs and first trimester abortions. Microvascular APS consists of small vessel involvement, especially pulmonary renal. The catastrophic APS is rare, but it's life-threatening form of APS, characterized by thrombotic complications, microvascular and macrovascular. Antiphospholipid antibodies. Key to diagnosis. A heterogeneous group of antibodies. They are immunoglobulins directed against phospholipids and phospholipid binding proteins. They may be transient, like following infections, or persistent, present on 2 or more occasions at least 12 weeks apart. The commonly assayed APL include anti-cardiolipin antibody, ELISA technique, anti-beta-2 glycoprotein 1 antibody, IgG and IgM with ELISA technology, and lupus anticoagulant. When to suspect antiphospholipid syndrome? Otherwise unexplained thrombotic events, venous or arterial. Adverse outcomes related to pregnancy, especially IUDs and miscarriages. Patient with livedo reticularis, valvular heart diseases, pulmonary hemorrhages, thrombotic microangiopathy affecting the kidney. Systemic autoimmune diseases, especially SLE. Otherwise unexplained thrombocytopenia, prolongation of activated partial thromboplastin time. So in my patient, during the early months of follow-up, it may be just case of unexplained thrombocytopenia, which is contributed to leptospirosis or dengue. So how do we start workup? Full blood count will show thrombocytopenia, which is persistent. The baseline coagulation testing should be done, including prothrombin and APTT. Serum creatinine and urine analysis should be there, which will be helpful to identify kidney involvement, like in SLE. The SLE testing is essential if your patient with clinical features suggestive of SLE. The timing of testing, the initial testing is usually done shortly after the clinical event. Should be followed by confirmatory testing at 12 weeks later. Patients already on anticoagulants. The test for anti-cardiolipin and anti-beta-2 glycoprotein 1 antibodies, these results are unaffected by anticoagulation, but the different anticoagulants have variable effects on lupus anticoagulant test. There is stratification based on antiphospholipid antibody profile. There are 3 categories: high risk, intermediate, and low risk. The high risk profile is being considered as persistently positive lupus anticoagulant with or without persistently positive moderate to high anti-cardiolipin and beta-2 glycoprotein 1. The high titers are being considered above 80 units. Some experts consider triple positive results, that is lupus anticoagulant, anti-cardiolipin and anti-beta-2 glycoprotein positivity to be associated with highest risk of clinical complications. The moderate risk profile, a negative lupus anticoagulant test with persistently positive moderate to high titers of anti-cardiolipin and anti-beta-2 glycoprotein. My patient is under this category. Low risk profile. Low risk profile, a negative lupus anticoagulant test with persistently positive low titer of anti. The evidence for primary thrombotic prevention. This was my first question actually. The evidence for primary thrombosis prevention in individuals with antiphospholipid is mixed, with limited data suggesting a possible benefit from aspirin. So in my patient, if we have detected him early, we could have started him on aspirin. Initial management of acute thrombosis. The confirmatory testing of APL must be performed at least 12 weeks after the initial testing. Still, the initial choice of anticoagulant is largely based on clinical suspicion for APS in the setting of new venous or arterial thrombotic event. In individuals with suspected APS, warfarin is typically preferred over direct oral anticoagulant, although DOAC may be reasonably used in selected individuals. Secondary thrombosis prevention, long-term anticoagulation. For most non-pregnant individuals with antiphospholipid syndrome, suggest anticoagulation with warfarin rather than DOAC. Evidence suggests that DOACs are less effective than warfarin for recurrent thrombosis prevention in patients with APS. The duration of antithrombotic therapy for most individuals with APS and unprovoked thrombosis recommend lifelong anticoagulation. That is, despite anticoagulation, adding aspirin, hydroxychloroquine, using higher INR range, or switching to low molecular weight heparin are the options. Monitoring includes coagulation studies, full blood count, and renal functions regularly, at least every 6 to 12 months. Take-home messages. Persistent thrombocytopenia could be easily missed unless we closely follow them up. These patients are usually clinically well and tend to default, as my patient did. They're usually reluctant to go for private sector investigations due to economical constraints. So it's a challenging task. Thank you.
Audience at the end of the both presentation. So let me to introduce the next speaker today. The next speaker is Dr. Dhanushka Ratnayaka, consultant neurologist, DGH Mahatali. Dr. Dhanushka Ratnayaka, MBBS Kelaniya, MD Colombo, MRCP, MRCPE, and overseas training at Royal College of Physicians, United Kingdom. He worked as consultant neurologist at DGH Kegal and Teaching Hospital Batticaloa. He is going to talk on life save or life loss. Over to you, Dr. Dhanushka.
First of all, I would like to give my sincere thanks to Ceylon College of Physicians for inviting to do this talk today, and also for the invitation and continuous support actually given by Dr. Amara Vitarna when he was working with me when he was working in Marvanel Hospital. I was the neurologist in Kegal. Okay, so moving to my presentation, life saved and life lost. This is actually a case when I was working in
Yeah.
Okay.
Now,
Okay.
okay.
This is my. You can see, I think, the slides now. So this is a. This was a case which I was involving in the management in Batikalo, and this was a call actually from A&E. She was a 32-year-old patient in her first ongoing pregnancy with POA of 36 weeks. And she had been having intermittent breathing difficulty, which was got worse for 2 days, and then she came to the A&E. Going back to the previous history, 3 months ago, she had developed generalized fatigue, nausea, and occasional episodes of short of breath after working. And she has attributed all these symptoms to her ongoing pregnancy. And she sort of did not seek any specific medical advice at that point in time. But there had been a very correct decision by the obstetrician who managed the case, who managed her pregnancy. He had made a neurology referral, but unfortunately, the patient did not attend to the referral. And she, apart from this breathing difficulty, she had new onset swallowing difficulty as well as sort of a dysarthria, speech difficulty. There was no chest pain, no palpitation, no cough or fever. She denied any double vision or eyelid drooping, no headache, and she was complaining that she cannot raise her neck. In my examination, she was dyspneic, but not cyanosed, and she was afebrile. There was no ptosis, and eye movements were all full, no diplopia. And she was having fluctuating bulbar weakness. She was not able to swallow, and even her dysarthria was variable. And her neck extensors are weak, and there was proximal weakness in her upper limbs, which was asymmetrical, actually left more than the right side. Lower limb examination was normal, and all her reflexes were intact with a normal sensory examination and flexor plantar response. These are the initial investigations we ordered, and their reports. Full blood count was normal, CRP 16, ESR was 32, clotting was normal, and this was initial ECG, which I think is normal. Renal functions, liver functions are normal. Serum calcium was normal. Potassium was normal, 3.9, and RBS was normal. This is the blood gas done at the A&E actually. So now if you go through it, you can see there is carbon dioxide retention with almost normal oxygenation. And lactate was normal. So can you guess the first idea that I got into my mind as a physician from a center where there are no second line neurological investigations? For instance, we don't have nerve conduction EMG in Batikalo. Actually, there is a nerve conduction machine, but there was no neurophysiologist to do sophisticated other second line tests. And this was the idea actually I got. As usual, I mean, this is a maternal case, and I'm going to deal with a difficult case. So do I have to transfer this patient for a center where there are specific facilities? And then I thought of the possibilities. Could this be a myasthenic syndrome? Because she has got predominant bulbar involvement. If you think it in a specific terms, it could be anti-musk myasthenia. Adult onset Pompe species. LEMS, Lambert-Eaton myasthenic syndrome. Guillain-Barré you can have Guillain-Barré like this. You can have specifically not the AIDP type Guillain-Barré, but what it's called PCB variant, pharyngeal, cervical, and brachial variant, where you get bulbar weakness and maybe one-sided upper limb weakness and the neck weakness. That was another thought. And pulmonary embolism, which is common in during pregnancy, which can give rise to sort of shortness of breathing, although you cannot explain your limb weakness and all, or a demyelination syndrome, which are totally unrelated to ongoing pregnancy. Of course, in my presentation, I have included certain slides to discuss about few theoretical details. Few words about Pompe's disease. This is also called acid maltase deficiency or glycogen storage disease type 2, which is an autosomal recessive disorder and caused by a mutation in the gene of lysosomal acid alpha 1,4-glucosidase. And there are two forms actually. One is juvenile form and the adult form, which can present in later manner. And usually it is characterized by skeletal myopathy in a limb girdle distribution, which might be tallying with our case, although she has not having any lower limb weakness. And usually they end up with a protracted course leading to respiratory failure, which was actually there in our case. Regarding the second possibility, regarding first possibility that I was thinking about of the case, if you analyze the symptoms of anti-MuSK associated myasthenia gravis. Now, if you see MuSK positive and MuSK negative, they usually present with bulbar weakness predominantly. So both positive and as well as negative patients are predominantly present with bulbar weakness as well as respiratory failure. So those are the key sort of symptoms they usually come with. But at the same time, you can have other symptoms, collection of symptoms which are seen in other myasthenic syndromes where you will see acetylcholine receptor positive antibody, acetylcholine receptor associated myasthenia. So this was fairly matching to our case. Another slides to show the involvement of neuromuscular areas in MuSK-associated myasthenia. So you can see in this column, they usually have bulbar symptoms, as in our case. So they can have swallowing difficulty and predominant swallowing difficulty as well as dysarthria and neck weakness, apart from usual symptoms of myasthenia like ocular and predominant proximal weakness. So moving on to the case again. So we made a clinical diagnosis of generalized myasthenia, which is possibly anti-MuSK related because of based on the symptoms, and patient was admitted to the medical ICU. And we started with immediate management while we were doing the investigations, and we started initially in IV immunoglobulin 0.4 grams per kg daily, and prednisolone 50 milligram, and symptomatic treatment for the myasthenia, which is pyridostigmine 60 milligram 6 hours. We started DVT prophylaxis, and I referred the patient to obstetrician to look after the baby. And we had investigations as well as we arranged certain specific investigations at this point in time. Her CPK was normal, and I was very fortunate that the patient's husband was very keen on getting done investigations, but I don't think in most of the centers there is access for these specific antibodies which are done for myasthenic syndromes. Luckily, I was able to send blood for anti-acetylcholine receptor antibodies and blood for anti-MuSK antibodies. I think at that point it cost about more than 80,000 for the both test. And when the test was ordered from the lab, they confirmed that you cannot see the results at least in 2-3 weeks time. So it is basically a clinical diagnosis that we had to continue with our management. And we got a contra-CT brain done. Although she's pregnant, we had to do this, and we got the consent and did the CT, which excluded any brainstem problems. Although it is not the ideal diagnostic test for demyelination, which we should do MRI brain, which was not available in, which is at the moment also not available in Batticaloa. And CT test done. Actually, these all test CTs were done on the same day, and there was no evidence of thymoma. We did lumbar puncture, which was within normal limits. Within the first week, she underwent emergency cesarean section, and healthy baby was delivered. That's what I wanted to highlight, actually. So we saved one life. And the baby did not have any features of transient neonatal myasthenia gravis. There was some improvement in her ABG with regard to the CO2 retention, but there was she was at that point in time also was with the maximum ventilator support. Very minimum clinical improvement, but again it is variable. At the end of the first week, we started with total plasma exchange as the next line of treatment, because she was not now improving with the IVIG and oral steroids and with symptomatic treatment. 5 cycles were done, and at the end of 5 cycles, she was able to tolerate SIMV mode in her ventilation. There was considerable improvement her neck extensors at that point in time, so which of course was promising me to assume that this patient can be managed only in Batticaloa. But one day, suddenly she became acutely breathless and had a significant desaturation, and we did a chest X-ray, and if you can see the what is on the left side is the initial chest X-ray that we did, and the what is on right is at the time of dyspnea. We discussed the X-ray with radiology team, and the diagnosis was left-sided lung collapse, which was thought to be due to malposition of the ET tube, and it was adjusted by the anesthesia team and the subsequent improvement in the chest X-ray, and dyspnea was fairly improved. During the 3rd and 4th weeks, patient underwent tracheostomy because she was difficult to still wean from the ventilator, and then one day suddenly she developed acute onset painful left leg swelling with the duplex evidence of DVT in the popliteal vein, and she was started with warfarin. This is of course while she was on enoxaparin actually, but unfortunately she developed this DVT, which was radiologically confirmed, and started back with warfarin. Because there was ongoing and fluctuating hypercapnia, we decided to repeat another cycle of plasma exchange followed by IVIG. And the last option for these kind of cases is to consider rituximab. And at that point in time, I actually, up to that point, of course, I was getting second opinions from National Hospital neurology team, because I had a idea that if in case the patient is not going to improve and to further evaluation, she has to be managed in a tertiary care center. So during the 3rd and 4th weeks, I was waiting for a bed in ICU bed actually from National Hospital to transfer the patient. But unfortunately, she developed another episode of left lung collapse. And this was at that point, patient was referred to respiratory team, and they arranged a fiber optic bronchoscopy, and there was a huge mucus plug which was removed, and with the complete recovery of the lung collapse. And by this time, we had reports of our certain blood tests that we sent at the beginning, and or both antibody tests were came as negative. And patient was transferred to the National Hospital Neuro ICU. Some aspects about what is seropositive and seronegative myasthenia, which I actually wanted to include here, because now it is totally different from what we learned in the past. We initially categorize all acetylcholine receptor antibody negative cases as antibody negative myasthenia, but now it is different because there are other antibody panels that we can do, including anti-MuSK antibodies and low density lipoprotein receptor related protein, that is LPR4 antibodies, which are usually not available in our setup. But those who are not having any of those antibodies, that is acetylcholine receptor antibodies or anti-MuSK antibodies or LRP4 antibodies, are now called seronegative myasthenic patients. Now there had been there was 2 lung collapse during the treatment for this patient's myasthenia. So is it associated with generalized myasthenia? Yes, I mean, there are cases. I mean, this is a case reported in 2002 in Neurology India, in a patient with myasthenic crisis in ICU. There are various mechanisms that will explain recurrent lung collapse when you are treating a patient with myasthenia. So this report says 6 patients received mechanical ventilation for myasthenia, and patient can get lung atelectasis and pneumonia, and ventilator associated other complications, and they can have recurrent lung collapse due to increasing mucus production, because you are giving a lot of anticholinergic medications. This is the summary of those cases. This is what I was talking about. The only significant problem may arise when acetylcholine medication, acetylcholine receptor and anticholine esterases are introduced. They will increase the airway secretion and thereby increase the risk of atelectasis as well as mucus plug formation. And as in our case, bronchoscopy was a successful way of treating it. So possibly the first case also may not be due to the first lung collapse in my case, may not be due to the malfunctioning of the ET tube. So maybe another mucus plug which might have spontaneously dislodged. She underwent RNST, which I was not able to do in Batticalow. RNST is repetitive nerve stimulation test, which is the test for which is one test actually for confirming your diagnosis of for myasthenia. And I mean, this is of course difficult to see, but I didn't include any charts or waveforms to show, but there is the lower down in the chart, repetitive stimulation study, you will see a decremental pattern when you are giving stimulation to various nerves, including accessory and ulna. So there was a this was the conclusion actually. RNST of the accessory nerve, which is the trapezius muscle, showed a significant decremental pattern bilaterally, which was confirmatory of myasthenia. So although, so this is a at the end, this is a case of possibly antibody negative myasthenia. Again, clinically, it could be anti-MuSK related syndrome. And there were no neurophysiological evidence to support Guillain-Barré syndrome, which was a differential diagnosis at the beginning. These are the some of the theories which are important. So in generalized and ocular myasthenia, if you take acetylcholine receptor antibodies, in generalized, you will see in about 80 to 90% of the cases, and in ocular variant, you will see in about 40 to 50% of the cases. So there is a another percentage where there is negative, but still they are myasthenic actually. So if you take anti-MuSK, it is in generalized myasthenia, you will see about 50% of the cases. And if it is ocular presentation, then it is less than 10. And if you do the repetitive nerve stimulation to diagnose, you can only diagnose generalized myasthenia in 75% of the cases, where that means you might get a negative RNST even if your patient is having generalized myasthenia. So the negative test does not exclude myasthenia. So it is basically a clinical diagnosis which you are going to prove with your RNST or antibodies. So it is a collective decision that you have to make by considering the history, examination, and if you are lucky with a positive RNST, and if you are not lucky, then it will be negative, but still you have to make your diagnosis at the end. The most sensitive test, which is called single fiber EMG, is positive in, I mean, if you take ocular or generalized, almost in both varieties, you can diagnose more than 95% of the cases. During the last week, they are in National Hospital. She underwent another 5 cycles of TPV, which I was planning to start at Batticaloa, and patient improved to a degree where they were able to transfer the patient back to Batticaloa. But unexpected thing happened just before the transfer. She developed unexpected massive bleeding through her tracheostomy site. So she actually, after sort of a lengthy resuscitation and several blood transfusions, we lost the patient, and post-mortem finding showed very unexpected collection of things. Tracheostomy opening was fibrosed, and there was no blood seepage into the mediastinum. The right brachiocephalic trunk situated abnormally higher up into the neck. So there was sort of a repositioning of the brachiocephalic trunk towards your tracheostomy site. And there was a brachiocephalic fistula connecting to the tracheal wall with a necrosis at the tracheal wall. So there was full of blood in the trachea as well as within the lung. So at this point in time, we were worried about the case actually because we lost the case, but there was very important learning point out of this death actually, which we must keep in our mind. I mean, this has been reported in the world, especially this brachiocephalic artery fistulas, especially after prolonged tracheostomy, is being reported. And this is one case report. And there was another one, innominate artery fistula. There are not much, but few cases. So what they have found is, several authors have found, there are contributing factors to develop these kind of fistulas. One is, if you make a very low set tracheostomy, that is very below the third or fourth tracheal rings, and if you use overinflated cuffs, and especially as in our case, prolonged tracheostomy, and if the patient is having neck deformities chronic, then there is a chance, high chance, that you will get these sort of fistula. So actually what has happened was, when you sort of move, when you are, say, when you are sucking out, you can have tearing of your blood vessels from the fistula, and then you can have massive bleeding, and you will lose the patient there. So this was the main learning point that we wanted to share. And my take-home messages are: anti-MuSK myasthenia should be suspected in patients with predominant bulbar weakness and respiratory compromise, as in our case. And recurrent lung collapse is not uncommon during myasthenic crisis, and this is seen in most, not most, but it is a common finding in ICU setup. And tracheo-arterial fistula, although it is a rare complication, it is actually life-threatening complication, which you have to think and, you know, take precautions. And of course, management of myasthenic patient during pregnancy is challenging, as in this case. And you should always get your expert involved to get a proper outcome. Thank you very much.
Thank you very much. Thank you very much, Dr. Dhanushka, for presenting very, very interesting case and sharing with us that is of myasthenia gravis in pregnancy, and she developed a lot of complications, lung collapse, and tracheoarterial fistula, and that's a very, very challenging case. Thank you very much once again, Dr. Dhanushka, for very interesting case presentation. So now we are coming to the Q&A session, and yeah, let's see. Yeah, there is a question in Q&A box. Let me to see the question first. Yeah, these questions go to Dr. Dhanushka. The question is, in resource limited settings, demonstrable muscle fatigability is clinically diagnostic of myasthenia, and would suffice initiation of specific treatment? Would appreciate your views, please. Please.
Yes, I think even in the guideline, what they say is, I mean, sort of most of, not most, but probably there are a lot of neurological diagnoses where you can't wait until you confirm your diagnosis. So this is one actually. This is one out of those. And if there is clinical suspicion, you can start treatment, but at the same time you have to take certain precautions as well. Now, for instance, now if you have access to RNST, you could delay starting pyridostigmine because it will affect your diagnostic accuracy. Otherwise, with clinical grounds, you can start with your treatment because, as I mean, if you go through my case now, even for antibodies, you have to wait for some time to get those reports, and unfortunately, our patient's report came as negative. So still, you are not able to exclude your diagnosis, and cases retrospectively or lately diagnosed with RNST, which was sort of we were lucky to have abnormal RNST, but at that point in time, also if it is negative, I think if we started the treatment as a myasthenia and patient showed a improvement towards the end, although we lost the case with not directly linked to the myasthenia, patient died. So it is recommended to start your clinical with your treatment on clinical grounds.
Okay. Thank you, Dr. Dhanushka. And yeah, may I ask a question from Dr. Ravindra? Ravindra, if your patient is getting recurrent adverse thrombotic events, what management options available?
Yeah.
You discuss little, what are the other possible available management options?
Yeah, possible management options. What they say is you can add on aspirin to the warfarin. Usually they recommend INR of 2 to 3, and you can add on aspirin to that. On the other hand, if you think that patient is getting recurrent thrombotic episodes, you can go for a higher INR range rather than 2 to 3. So you can go up to 3.5. So that's what recommendations for recurrent adverse thrombotic events.
Okay. Thank you, Dr. Ravindra. And also, another, may I ask a question from Dr. Dhanushka? Yeah, you may get seropositive or seronegative myasthenia gravis. Is there any prognostic difference between those two cases, like seropositive and seronegative myasthenia cases? Prognosis?
Prognosis, there is no, but you can predict the clinical associations actually. For instance, seropositive acetylcholine receptor positive patients are more likely to get thymoma. So in your management, you have to attend to the thymoma as well. But on the other hand, in seropositive, even seropositive MuSK patients, they are not usually associated with thymomas. Likewise, the presence of antibody does not give a full picture of what is going to happen in your prognosis, but your management will differ on that.
Okay.
Direction of your other investigations will be changed depending on the presence of antibodies. And there is no link or relationship between the titer and the severity of the disease also.
Okay. Okay. Thank you, Dr. Dhanushka. And there's another question in the Q&A box, and these questions go to Dr. Ravindra. This is the question coming from our virtual participants, Dr. Lakmal Vitanage. And his question is, we used to discharge both dengue and we used to discharge both dengue and leptospirosis patient while having low platelets. What would we do to avoid missing those patients?
Actually,
Dr.
there's
Ravindra.
no proper guidelines. I haven't seen proper guideline for this thing in our country, but
Yeah.
I think it's better to follow up them at least 1 or 2 months with a full blood count. Although it's not common disease, antiphospholipid syndrome, if your patient is in a severe or moderate degree thrombocytopenia, it's better to follow up them at least once a month with a full blood count. That's what my gut feeling. When I inquired this with my hematology colleagues, they said there are no proper guidelines for this as well. So up to my knowledge, there's no proper recommendations for this type of thrombocytopenic patients following acute infections like dengue and leptospirosis, which is very common in our clinical setup. We contribute these thrombocytopenias for viral induced marrow suppression, which is in most of the cases, which is true, but 1 or 2 rare cases of my patient type will be missed. So if you suspect that it is not coming up, it's better to exclude other causes of thrombocytopenia, especially if they are in severe and moderate grade thrombocytopenic category.
Okay. Thank you very much, Dr. Ravindra. And in the absence of any more questions, let me to wind up the sessions now. And first, I would like to thank 2 speakers today, Dr. Ravindra Lokugamage and Dr. Danushka Ratnayaka, for accepting our invitation and share their experience. Also, I would like to thank CCP staff, audiovisual team, Mr. Nalina, and sponsor Merck Pharmaceuticals for their continuous support, and all virtual participants who are joining with us today. Thank you very much.